different topic to discuss. I hope I have briefed it out completely for you guys to take some home points. Let's start. First of all, what is autoimmune disorders of the nervous system? Autoimmune disorders of the nervous system affect both the central and the peripheral nervous system, which include the brain, the spinal cord, and the peripheral nervous system. Peripheral system consisting of the nerves that connect the CNS with the limbs and the other organs. Combined, these disorders are known as the demyelinating disorders of CNS, along with the autoimmune encephalopathies, which we will discuss in the later slides. Firstly, demyelinating disorders of the CNS. Acquired demyelinating disorders of the CNS are rare disorders occurring with an annual incidence of 0.5 to 1.66 per 1 lakh children. Neurological dysfunction in these disorders are caused by immune-mediated attacks on the white matter insulating the brain, optic nerve, and the spinal cord. There are mainly two antibodies playing an important role in demyelination. The aquaporin 4 antibody, which is present on the astrocytes, and the myelin oligodendrocyte glycoprotein antibody, which is present on the myelin sheaths of the nerves. This basically is characterization of pediatric demyelinating orders clinically. We have to see these all 4 points to look out for different types of demyelinating disorders present in the children. Firstly, to look out for is the localization of neurological deficits. In various demyelinating disorders, there is a single site such as a spinal cord involved in cases of transverse myelitis and optic nerve in optic neuritis. There are multiple involvements of lesions in the cord and optic nerve which are seen in NMOSDs disorders. We'll discuss it later. Second is the presence or absence of encephalopathy. This is a very important point to distinguish it between ADEM and multiple sclerosis. ADEM is, we'll discuss later, ADEM, the encephalopathy is the hallmark of ADEM, but in multiple sclerosis, it can present later on, in later on stages. Third is the disease course. Whether is it monophasic versus repeated attacks involving either the same reason or the new CNS reason, as seen as multiphasic ADEM. Fourth is the presence or absence of specific antibodies, the two antibodies which I have discussed above. Now coming on to the types of demyelinating disorders of CNS. There are mostly 6 types of demyelinating disorders of the CNS. The most commonly seen in the pediatric population is acute disseminated encephalomyelitis. The second is optic neuritis, transverse myelitis, multiple sclerosis, neuromyelitis optica spectrum disorders, and MOG antibody spectrum disorders. Discussing the first one, which is of utmost importance for us, acute disseminated encephalomyelitis. ADEM. ADEM is an inflammatory demyelinating event of early childhood. It presents with an acute onset of polyfocal neurological defects. Polyfocal is different, lesions are present at different times in the patient, and which is accompanied by encephalopathy. Coming to the epidemiology, it occurs mostly in the mean age group of 5 to 8 years with a slight male predominance. It is usually monophasic, but recurrence can occur if recurrence is more than 3 months, or if there is a new lesion present, then it is termed as multiphasic disseminated encephalomyelitis. A seasonal distribution is also seen, mostly occurring in the winter and spring season. What is the pathogenesis of ADEM? Pathogenesis of ADEM is mostly dependent on 2 causes, the infectious causes and the post-immunization causes. 50 to 70% of cases seen of ADEM had a preceding viral infection in 15 to 1 month before the onset of the initial symptoms. The most common infectious causes are measles, mumps, rubella, Epstein-Barr, cytomegalovirus, influenza, mycoplasma pneumoniae, etc. ADEM is also seen post-immunization in immunization like rabies, Hep B, influenza, DPT, MMR, pneumococcus, polio, and smallpox. Out of these, MMR vaccinations are the most commonly associated with ADEM. Coming to the clinical features. The initial symptoms and initial features of ADEM consist of lethargy, fever, headache, nausea, meningeal signs, and seizures. The neurological signs develop later on, and it includes all the visual losses, cranial neuropathies, ataxia, motor and sensory deficits, bladder and bowel dysfunction. Urinary retention is a sign which we should look out for in cases of ADEM because it presents in an early onset. Urinary incontinence is in the later phases. And what defines ADEM is the encephalopathy. It is usually present in all the cases of ADEM, and it is a rapid onset encephalopathy. Encephalopathy is a hallmark of ADEM. How to diagnose ADEM? Mostly the diagnostic criteria are based on the CSF studies, MRI findings, and the serum findings. But the most common, the most valuable for us is the cranial MRI, in which we can see the typical bilateral large multifocal. You can see it over here. Multifocal edematous mass like T2 lesions with variable enhancement, and going into the gray matter of cerebellum and the brainstem also. These are the two MRI findings in the case of ADEM. Here you can see both the white matter and the gray matter are involved. And in this, only the white matter with asymmetric lesions are present in the white matter. These are also the findings of ADEM only. In slides A and B, you can see there are numerous asymmetric lesions. Presently, hyperintense subcortical white matter lesions are also present. In slide B, you can see a pulvinar lesion. A pulvinar nuclei is the largest nuclei of the thalamus, and it has a very strong connectivity with the visual cortex of the brain. So if any lesion is present in the pulvinar region, it usually has visual impairment. In slide C and D, you can see there is a ring enhancement associated with these lesions here. And this is the MRI finding after the steroid therapy has been given. You can see the drastic improvement in the last MRI. The differential diagnosis and treatment of ADEM. ADEM is a clinical diagnosis supported with MRI, CSF, and serum findings. The serum findings are lymphocytic pleocytosis is seen. Predominant lymphocytes are seen in the CSF culture. Elevated CSF protein is seen, and in 10% ADM, oligoclonal bands are seen. The treatment guidelines are empirical antibiotics and antiviral treatment. Drug of choice of antiviral is acyclovir. Should be considered while infectious evaluations are still pending. The core treatment relies on acute treatments of ADM or demyelinating disorders. The core treatment is high dose IV steroids. Methylpred in the dose of 20 to 30 mg per kg per day for 5 days. And the maximum dose should not go over 1 gram per day. Followed by tapering of oral prednisolone 1 to 2 mg per kg per day. If we see the symptoms are resolving, we can continue these both high dose IV steroids and oral prednisolone for a prolonged time. If there is no improvement in the child, we have to go for other treatment options, which include IVIG, 2 gram per kg administered over 2 to 5 days, and plasmapheresis, mostly 5 to 7 exchanges every other day. The last two treatment options are mostly seen in the cases of refractory or severe cases of ADEM. Prognosis.
If you have to shift from IVIG to plasmapheresis, is there a precaution? If you are given steroid, it's not respond. You're planning to just IVIG or IVIG with plasmapheresis. Is there some precaution or something which you find when you are going forward with this? Which one will you prefer to do first?
We would prefer IVIG first.
The IVIG is no response to plasmapheresis.
Yes.
The problem is when you give plasmapheresis, what your IVIG is providing you with anti. Whatever you supply. Right. So either you do the plasmapheresis first.
2 weeks gap.
First, we should do a plasmapheresis. After 2 weeks, we should try.
This is universal. I mean, my brother is having bulimia, but some neurological symptoms. So I asked the neurologist to go and see. What can I do? Every other day he is having a dialysis. So whatever the medicine I have been giving will be So if you are giving plasmapheresis, you are
Another question is, in the MRI finding, you have mentioned that similar clinical manifestation can also be mitochondrial disorder. So how will the MRI finding, how will it shift again and mitochondrial disorder? So what is the other saying? Helps you to think, okay, this is not mitochondrial, this is again or vice versa.
The recurrent lesions, like in multiphasic ADAM.
You don't know this multiphasic ADAM. Other child is not the picture will happen. So what particular thing in the MRI will kind of raise a red flag? Is this possibly ADAM or possibly mitochondrial?
Firstly, it will affect the high energy. Mitochondrial
Hypointense.
basal ganglia is high energy, and then peak also.
But even before that, there is a very symmetrical lesions. Mitochondrial disorders always very symmetrical manner. ADAM will usually not have a symmetry. Almost always asymmetrical. You have mentioned asymmetrical. That's why I asked. Because ADAM will almost always be asymmetrical. But mitochondrial disorders are very characteristic.
Symmetrical lesions. Coming to the prognosis of ADAM, most children experience full motor recovery after ADAM, but residual defects can be seen. Cognitive defects and behavioral changes are not uncommon. Coming to the second demyelinating disorder, optic neuritis. It is defined as the inflammation of one or both optic nerves. It can be idiopathic or can occur together with the inflammatory conditions like MS, multiple sclerosis, ADAM, or neuromyelitis optica spectrum disorders. Epidemiology. Optic neuritis is one of the most common of all acquired demyelinating syndromes. Typical presentation includes there is unilateral bilateral visual loss over hours to days, abnormal color vision, visual field loss, and sometimes a relatively afferent pupillary defect. Bilateral optic neuritis is more common in younger children and often associated with impending viral infection, preceding viral infection. In fundoscopic examination in some patients reveals an optic nerve head swelling known as papillitis. Diagnostic evaluation and treatment of optic neuritis. Visual evoked potentials are often used very commonly, and in younger children, VEPs can also detect any silent episodes of optic neuritis in the opposite eye. OCTs, optical coherence tomography. They can detect structural retinal changes such as RNFL, retinal nerve fiber layer thinning. MRI orbit, it may be normal, but usually it shows thickened optic nerves with increased signal on T2 weighted scans. Antibody testing in serum for both aquaporin antibody and MOG antibody is recommended to ensure prophylactic treatment. The treatment course is same as the ADAM, high dose IV steroids, methylpredate 20 to 30 mg per kg per day for 3 to 5 days. And if there are severe episodes of demyelination, we can go for IVIG and plasmapheresis. This is a orbital MRI of a 13-year-old girl. You can see the right optic nerve is thickened. You can see. You can see the arrow marked. The third disease in this demyelinating class is the transverse myelitis. It is a condition characterized by rapid development of both motor and sensory deficits at any level of the spinal cord. It has also multiple causes and can be idiopathic or secondary to all the infections we have mentioned. And it can also occur due to a direct infection like in infectious myelitis. Clinical features. Transverse myelitis is often preceded by a mild non-specific illness and minimal trauma or immunization. The main initial complaints of the patient is discomfort or overt pain in the back, depending upon the level of the lesion. And third is all these numbness, anesthesia, ataxia, areflexia, and motor weakness in the truncal and appendicular musculature at or distal. It occurs mostly at the level or distal to the level of the lesion. Urinary retention is a common and early finding. Incontinence occurs late in the course. The go-to point in this slide is rarely is the weakness unilateral. If unilateral weakness is there, It can be due to a presence of a hemichord lesion, which is associated mostly with multiple sclerosis. Diagnostic evaluation and treatment.
What
TM,
is the sensory loss register while at or distant? On level, the sensory loss should be at that level. So why isn't it mentioned? The reason for that.
I don't know that.
Sensory fibers rise, tendon spinal cord rise one level above. Injuries occurring at one level, not the level below. That's why at the level you will not get sensory. Because on the
Below
lower
the-
level, they have a one level.
Transverse myelitis is a diagnosis of exclusion. The differential diagnoses include GB syndrome, demyelinating disorders we have mentioned, systemic rheumatological conditions like SLE, meningitis and infectious myelitis, spinal cord infarction, arteriovenous malformations. MRI with or without contrast enhancement is essential to rule out a mass lesion. These are the MRI findings in the case of transverse myelitis.
Given the differential on two arts, right? In calcium, they have a
Huge,
for example,
ज़्यादा हो जाता है.
that's right. What's right? For example,
Here you can see in this slide, the slide, the arrow pointed, you can see the longitudinally extended transverse myelitis lesion in the spinal cord. And in the next slide over there, the arrow marked red, you can see a longitudinal extended lesion from C5 to T1 in the case of transverse myelitis. This is the lesion. Treatment and prognosis. The most important is the modulation of the immune response, which may be effective in decreasing the severity of the disease. High-dose steroids is the initial approach. If there is poor response to the high-dose steroids, we can give IVIG and plasma exchange are the treatment of choices. If transverse myelitis is secondary to an underlying disease, any underlying disease has happened and then transverse myelitis has happened, we can use rituximab and cyclophosphamide. Prognosis: older children with acute TM have a better outcome, with nearly 50% making a good recovery for more than by 2 years. The next disease is neuromyelitis optica spectrum disorders, commonly known as NMOSDs. It is basically a combination of optic neuritis and transverse myelitis. Presents with episodes of optic neuritis and longitudinal extended transverse myelitis. The main feature in this diagnosis is the presence and absence of aquaporin 4 antibody. Aquaporin 4 antibody positive and NMOSD is seen in older adults, while MOG antibody positive NMOSD is seen in children. And neuromyelitis optica is more common in Asians than in blacks or white. Clinical features. As it is a combination of both two disease, the presenting complaints are same as optic neuritis and transverse myelitis, or area posterior myelitis, a brainstem syndrome. And there are various clinical features like vomiting and hiccups. Optic neuritis and transverse myelitis can occur simultaneously together and may be separated by weeks or even years. Seizures or encephalopathy, like in ADM, are present in NMOSDs also. There are various endocrinopathies that are related with neuromyelitis optica: hyperinsulinemia, disrupted puberty, and obesity. Some autoimmune conditions like SLE, Sjogren's syndrome, and autoimmune thyroiditis are also present. These are the findings of MRI spine, brain, and MRI orbit in the case of NMOSD. In the first slide over here, you can see these spinal cord lesions, longitudinal extension seen in transverse myelitis. The second, you can see the atrophy of the spinal cord, which occurs mostly in the cases of multiple sclerosis. And in the latermost image, you can see bilaterally thickening of both the optic nerves, seen in optic neuritis and most commonly seen in NMOSD. For diagnosis and treatment, diagnosis of NMOSD is basically on the presence or absence of the aquaporin 4 antibody. In seropositive patients whom aquaporin antibody has been present positive, only one clinical criteria out of optic neuritis, transverse myelitis, and lepostroma should be present. While in seronegative patients, the diagnosis is made on basis of two clinical criteria out of the above mentioned. The treatment is minimizing CNS injury. Initial episode treated with methylpred, same dose 20-30 mg per kg for 5 days. If improvement is there, we can increase the duration of methylpred only. If there is no improvement, we have to give IVIG followed by plasma exchange. And rituximab can also be used both acutely and for relapses.
What sample would you send to one just track? What would that?
A sample.
What clinical sample? What's the patient's what's the sample? You get from the expert?
Serum antibodies level checks the
Is NMO ideally you should send pair
CSF.
More antibodies better.
CS.
More antibody no.
More antibody in serum.
So if you configure more with just a but in NMO they get just single antibody.
CNS. Myelin oligodendrocyte glycoprotein antibody. Coming to myelin oligodendrocyte glycoprotein associated disorders, the clinical features presenting with these disorders are mostly of the phenotype of the same we have discussed, and they are different from multiple sclerosis. But it overlaps with patient with ADAM and echoquerin 4 antibody positive NMOSC. MOG antibodies present in almost all of those with relapsing ADM. That is a multiphasic ADAM. In although multiphasic ADAM patients, MOG antibodies always present. Lab findings. MRI findings are atypical of multiple sclerosis. And in this MOG antibody disorders, there is widespread white matter involvement. This is a MRI axial T2 diffuse showing symmetric leukodystrophy associated with MOG antibody.
This kind of MRI is the characteristic of
Corporate number.
So basically, the treatment includes high dose methylpred and 20-30 mg per kg per day, plasma exchange and IVIG, depending upon the severity. These were all the demyelinating disorders which we have discussed, causing autoimmune CNS disorders. There is a whole list of non-demyelinating disorders which are classified as autoimmune encephalitis. It was a very long it was a very long list, so I have put mainly 4 or 5 encephalitis which are common we have seen. Autoimmune encephalitis is a group of clinical syndromes that can occur at any age. And antibody, and the specific thing about this is there is no demyelination occurs. There are antibodies present against the neuronal cell surface protein and synaptic receptors which cause autoimmune disorders. Symptoms may vary associated with the associated antibody. These are the 5 encephalitis I have mentioned. The most commonly seen is anti-NMDAR, which stands for anti-N-methyl D-aspartate receptor. After ADAM, this is the most common cause of autoimmune encephalitis seen in pediatric population. The antibody involved against this is antibody against GLU-N1 subunit of NMDAR receptor. The clinical symptoms which present in this syndrome is decreased verbal output, sleep disorders, seizures, dystonia, and rigidity. For diagnosis purpose, MRI is very non-specific of NMDAR. EEG always shows some abnormality, slow cycles are there, and in CSF we can see lymphocytic pleocytosis. The second one is because
investigation apart from CNS.
specific for
Not specific. This could be not any complication or any non-CNS examination, imaging or investigation. So, ultrasound abdomen.
to look out for.
Lot of them have paraneoplastic systems. Or in terms of functions, stand of paraneoplastic.
The second encephalitis is Bickerstaff encephalitis. The antibody responsible is GQ1B antibody, and the main criteria of
It's much less common. Secondary to malignancy,
Very common.
most common in adults.
In India, antibody to what's good. Adult is 30%. It's not common.
the Bickerstaff encephalitis antibody involved is GQ1B antibody. Syndromes are rapid progression. The main characterizing feature of Bickerstaff encephalitis is there is rapid progression of all these symptoms. Less than 4 weeks of bilateral ophthalmoplegia, ataxia, and decreased level of consciousness. The MRI findings are again normal in Bickerstaff. In the MRI finding of Bickerstaff, there are T2 weight scans showing lesions in the basal ganglia and brainstem, and CSF is normal. The third one is Hashimoto encephalitis, also known as steroid responsive encephalitis and autoimmune thyroiditis. The antibody involved is thyroid peroxidase antibody, and the
Extremely rare. And there are authorities who question whether how this exists.
The provider it's
The observer question is virtually
there are stroke-like symptoms, tremors, myoclonus, sleep, and behavioral problems. Diagnostic: 50% of these people have hypothyroidism with normal MRI and CSF findings. The next one is clippers. There is no specific autoantibody associated with clippers. The symptoms include diplopia, facial paresthesis, brainstem and spinal cord dysfunction. In MRI, there are symmetric gladonium lesions present in the MRI findings, and the last one is ROHAT. It is rapidly onset of obesity with hypoventilation and hyperventilation, hypothalamic dysregulation with autonomic dysregulation.
This is also a paradox. Had the patient unfortunately this is also
only
a paradox.
100 cases reported in the world.
But 101.
This was the cause is unknown, but it is mostly associated with neural crest tumors. And the symptoms which appear are hyperphagia, abnormal behavior, autonomic dysfunction, and hypoventilation. The diagnosis is also MRI findings are normal. Thank you.
Another one you just mentioned is observation paradox.
That
That is see get it possible.
Excellent presence.
Thank you so much.